Thank you so much. And thank you, Dr. Abbasi, for the wonderful invitation. And thank you to all the speakers. I learned more in the last hour than I learned in all of fellowship. So, it's always great to be on these webinars. You're asked to teach, but you actually learn more just from being here. So today I'm going to talk a little bit about patient-specific anatomy. And it was great to see Dr. Abbasi talk about the transfacet approach, and we'll describe that as well. Here are my disclosures. So we're going to talk a little bit about three types of TLIF. The traditional MIS TLIF that most of us were trained on. We're going to talk about the Trans-Kambin percutaneous TLIF. Then we'll talk about the transfacet TLIF. We're going to talk about indications and limitations of each of them. And then I hope to talk about the patient-specific TLIF, and then my current algorithm of deciding which type of TLIF I'm going to use. So if we look at the different flavors of TLIF, most of us have been trained to do either an open TLIF, where we do a hemilaminectomy, we find the theca, we push it to the side, and then when we do it under a tube, we call this a MIS TLIF. But if you're trying to put a big cage in there and you have a little small nerve, you can get a CSF leak or a nerve root injury. There's not much room within a tube. The next option is this transfacet pathway. For some of us, this may be difficult because it's, maybe foreign to us. And then the last one is through Kambin's triangle percutaneously. And as people have really talked about, Dr. Parviz Kambin was a real giant that we owe a lot of gratitude to. I think that Dr. Wang in Miami have done a good job talking about it being a three-dimensional anatomical place, and it should be called more of a prism. We did this systematic review looking at Kambin's triangles, mostly using anatomical structures. And we found that as you go caudally in the spine, you'll find that the Kambin's triangle area increases. And then as our endoscopy folks will tell us, if you do a foraminoplasty and take off this part of the SAP, you can actually double the size of Kambin's triangle. One of the key things to realize is that, that was done anatomically, but as surgeons, we deal with pathology. And so if you have a disc herniation and or a spondylolisthesis, that area can actually decrease. Now, a lot of the work was done using anatomical structures or CT scans, but as other speakers have spoken of today, what's critically important is that exiting nerve root and the DRG. So what we did, my background is in neurosurgery, so we actually went back to the cranial software, the BrainLab software, and we started to map out the nerves individually. And then we can actually measure preoperatively using standard MRIs how big Kambin's triangle is. And so if I don't have to do a direct decompression, I can always choose the side of the larger Kambin's triangle. We also found that you can know the traps before they come here. So here's an example where we're able to see before surgery that there's a conjoined nerve root. So we're not going to go through Kambin's triangle there. If you take the nerve into consideration, we showed that that will actually decrease substantially the area that you have. So now it makes us even less confident. And then we found that for some people, Kambin's triangle is just too small. This one here, we measured a maximum diameter of 6 millimeters. So that's going to be too small. And so now we know this, so we're not in the operating room, floundering and having problems. We can actually know before we go to the operating room, this may not be the best case for a percutaneous TLIF. And so then we started to use the transfacet corridor. And so this is something that was popularized by Zach Ray at University of Washington University in St. Louis. So here we are. This is caudal, this is rostral, this is the IAP, this is the SAP, and you stay within this corridor here. And so we mapped this out using our MRIs again. And so we could see, that this transfacet pathway, we could compare it at each level, and we found certain interesting things. This paper was just published this month. You can look at the area of the corridor. We found that in general, the transfacet corridor will be larger. And you can look at the maximum permissible cannula diameter. So when you're thinking about putting a cage in and so on, you can actually decide, what are the maximum dimensions of the cage that you're going to put in. We found some very important things. We found number one, similar to Kambin's triangle, the area increases as you go up, as you go down the spine, sorry. However, and this is really important, is that when you have a pathology like a spondylolisthesis, the transfacet pathway actually gets larger because that joint, it gets diastased and you have a larger working area. So it actually becomes safer with grade 1 and grade 2 spondylolisthesis. We also found that no longer are the nerves the limiting factor, but in fact, the posterior disc height is the limiting factor. So the area actually is big enough, and so you don't actually have to worry about the nerves. You only have to worry about the posterior disc height being your limiting factor. So here's a case. This is a 30-year-old gentleman with a grade 2 spondylolisthesis. You can see here he's not a good candidate for an ALIF. He did not want a lateral surgery. So what we did for him is we did the segmentation. We planned out this transfacet pathway. You can see here we're avoiding the exiting nerve root and the traversing nerve root. We put in the screws, and then it's my standard operating procedure to get a CT scan, make sure my screws are good. And then we're actually able to merge the intraoperative CT to the preoperative MRI. And then as I'm drilling in the transfacet pathway, I have this augmented reality or heads-up display telling me where I am and make sure that it's safe. And so right now, we're manually segmenting out the nerves, but we're working on automating this so that it can become in anybody's armamentarium. Now, you would correctly say that, while with the Trans-Kambin, you're not really decompressing. The MIS TLIF, you can decompress. And we showed that, it does make a difference for those people that have the percutaneous TLIF. They use, 40% less opioids, and that's really important. And I think a lot of the other speakers have talked about this. So for me, that's where I got into endoscope, is that maybe there's a way to kind of bridge those two gaps. And then not only are we doing patient-specific trajectories, but we're also doing patient-specific implants. So you can see here, these implants now land very nicely on the end plates and don't cause subsidence and so on. So here's another case, case that we see a lot, grade 1.5 spondy. So what we do for this person is we measure their Kambin's triangle. It measured at 7 millimeters. We measured their transfacet pathway. That's 11 millimeters. I felt more comfortable doing a transfacet pathway. So that's what we did for this patient. So in terms of our current algorithm, I do a lot of ALIFs. I do a lot of laterals. If it's a significant deformity, though, I think that Dr. Hazem's work is great. I think that in most cases, I'm doing either an MIS or hybrid anterolateral approach if it's more than 3 levels. If it's not, if it's 1 or 2 levels, maybe 3 levels, I'm measuring this Kambin's triangle. And if it's big enough, if it's not big enough, then I'm going to have to use the transfacet pathway, which Dr. Abbasi talked about, plus or minus a decompression if I need to do a direct decompression. If the Kambin's triangle is big enough, then I need to think about whether I need to do a direct decompression or not. If I don't have to do a direct decompression, I think this is the perfect case for the Trans-Kambin percutaneous TLIF, because I know Kambin's triangle is big enough. I don't need to do a decompression. All I need to do is decrease the spondylolisthesis and do a indirect decompression. If I do need to do a direct decompression, there are actually 2 options now. You can do the Trans-Kambin perc TLIF with an endoscopic decompression, or you can do the transfacet TLIF with a decompression, most likely tubular, since you're doing that. So just to conclude, I think that the TLIF is a really powerful technique. And I think patient-specific pathology and pathology-specific planning is extremely important. Thank you so much.